All right. Thank you all for joining us today. My name is Dr. Phil Finnemore with WorkFitME Mobile Physical Therapy. I have a fully mobile physical therapy practice where I specialize in helping busy Maine professionals and business owners to maximize their physical performance so they can live a happy, healthy, and wealthy life doing what they love with who they love. I am very excited to be joined by Dr. Alexandra Barr from Coastal Maine Direct Care. And Dr. Barr, I will hand it over to you so you can introduce yourself and Coastal Maine Direct Care.
Great. Yeah. Thank you, Phil. And thanks everyone for joining us today. So I'm Dr. Alexandra Barr. I have a practice called Coastal Maine Direct Care in Falmouth, Maine. My background is in family medicine. So I did a family medicine residency and then did a geriatric fellowship. So I'm also board certified in geriatric medicine. So I mostly see older adults. I'm also a DO as well, and I can get more into that later, but I do osteopathic manipulation in my office, as well as just seeing patients. And I also make house calls, home visits. I see patients in the office as well as different nursing homes and facilities as well. So that's a little bit about me, but I'm happy to be joining Dr. Phil today. We do these workshops every now and then just to talk about various pain and disease. And so it's a really fun way to learn more about it. So thanks for
Definitely.
having me.
Of course. Thank you very much for taking your time and joining us this morning. And want to thank all of you again for taking the time out of this beautiful Saturday morning to join us as well. So just a little bit about what we're going to go over today. We're going to be talking about knee pain. We'll be talking about a couple things in particular, mostly some arthritis, meniscus injuries. If we have some time, might touch a little bit on pain coming from the kneecap, because that's something big that I see and help people with a lot. But we just want to give you a little information about the impact of these things a little bit and how they really become painful, and some conservative treatment options, because with things like arthritis and even meniscus tears, surgery, medication, and injections are not the only option that we have. And if we can avoid invasive procedures to treat these things effectively, not only in the short term but in the long term, I think we're all for that, right? I think if we can avoid going under the knife or having something injected into our body, the more of that, the better, or the less of that, the better, I guess. The more conservative, the better. So to start with, I'm going to hand it back over to Dr. Barr. She's going to go over some things in regard to arthritis and a few other things, and we will get started here. So Dr. Barr, take it away.
Great. Awesome. So I'm going to share my screen with all of you. All right. So can everyone see that okay? Or
Yes.
Phil, can you see that? Okay.
Yeah, we're good.
Awesome. Okay. So we're going to be talking about knee pain and conservative treatments to try to avoid surgery, as Bill was saying. So why are we talking about knees today? The knee is the largest articulating surface of any joint in our body. And depending on the activity, the knee can support 2 to 5 times a person's body weight. So that's pretty significant. And chronic knee pain affects 25% of adults and has a significant effect on daily function and quality of life. So if I see someone in my office and they're having knee pain, usually it's affecting how they're walking. Pain certainly can affect your mood and just your day-to-day functioning and quality of life. Knee pain can increase your risk of falls. It can make, your muscles weak. And so that's why we're really focusing on knee pain today and how to manage it and treat it in a conservative manner to basically improve function and improve quality of life. And that's really what we're all about. So first, when I see someone in my office, just, for an initial evaluation or exam, I want to do a thorough history taking. So I want to ask questions like, where is your pain located? Is it one specific area? Is it diffuse or all over, the knee? How long has it been going on? How severe is it? This will sort of help me figure out the diagnosis and why you're having knee pain. Also, it could be referred pain. So a lot of people might also have hip pain that's causing the knee pain, or ankle pain, back pain, sciatic joint pain, things like that. So we want to figure out if that's part of why you're having the knee pain. Ask about any constitutional symptoms. So are you having fever, weight loss, night sweats, sort of red flag symptoms that we would need to talk about. Or if the patient has had any other prior treatments or any surgeries. Those are really important things to figure out. Also, how did the knee pain, how did it start? Did you fall down a flight of stairs, or was just something that kind of over time became progressively worse and worse? So that'll kind of, lead me to a direction of what's causing the knee pain. And of course, after the history taking, I want to do a thorough physical exam. So inspection, looking at not only the knee, but really your whole body, back, hips, legs, ankle, to try to, see if there's anything out of joint or anything going on. And of course, palpation, we learn a lot with our hands through touching and evaluating that way. I don't usually do labs, although if I'm thinking there might be like a rheumatic disease or rheumatic arthritis, I'll certainly order labs for that, or, but usually for straightforward knee pain, I don't always order labs, just kind of depends on the situation. Imaging. So X-ray usually, is pretty important if I want to rule out a fracture or something broken. MRI is really good for any sort of ligament tear or meniscus tear or something like that. So again, just kind of depends on the history and the physical exam when I'm going to order to figure out what's going on. So the number one cause of osteo or knee pain, like why people come to my office and have knee pain, usually people have osteoarthritis, especially because I see older adults. There's a lot of osteoarthritis in my office, a lot of patients who have a lot of chronic pain from this. So this is really what I wanted to focus on right now. So osteoarthritis is the degradation and thinning of our cartilage in our knee or hands or hips or, different joints of our body. It's really important because it is the leading cause of pain and disability worldwide. And what are some of the risk factors? So older adults, so age greater than 50, female, high BMI, so people that are overweight or obese, you're going to put more pressure on your knee joint, and that's going to cause more of the thinning of the cartilage and more of the arthritis. If you ever had a previous knee injury, knee surgery, or if you're doing a lot of activities that place a lot of stress on the knee, any family history of osteoarthritis, and I have a picture here. These are called Herbert's nodes. And so a lot of people with their hands, you see those nodular areas in the hands, that's significant for osteoarthritis of the hands. So you can have osteoarthritis in other joints of the body as well. So usually the diagnosis is pretty clinical. You can see it on an X-ray, but it's pretty straightforward. So usually you have a person who comes to the office. The median age for getting osteoarthritis is around 55 years old, so an older adult. You're doing an activity that's causing joint pain. Usually my patients will tell me, I wake up in the morning and I don't have any pain. I'm not really stiff. it's pretty mild. And then as I'm doing my activities during the day, the pain is getting worse and worse and worse. And so that's pretty indicative of osteoarthritis. And then, of course, we talk about functional limitations. So they're not able to walk as well as they used to. They're not walking as far as they used to. Going up and down stairs is becoming harder. So that's pretty diagnostic. And then usually on my exam, I find a lot of crepitus, and what that means is just kind of cracking on the joints. If you're ever moving around and your joints are going, kind of crackling, that's crepitus, and that's pretty indicative of arthritis. Or if there's any restricted joint movement or any enlargement of the bones. So if severe osteoarthritis in the knee, you're going to have a pretty large knee. Then also it's correlated to other diseases. So people sometimes can also have cardiovascular disease, diabetes, hypertension, obesity, like we talked about before, depression. So that can also sometimes be related. So again, it's good to have a thorough history taking to see what all is going on. And so let's talk about, how do we manage this? So of course we want to avoid surgery. We want to avoid anything pretty invasive. So I always start with, conservative treatments like exercise. And we'll be talking more about this later, muscle strengthening, walking, Tai Chi is good, cycling, yoga, swimming or any, water aerobics. Those take a lot of the weight off of your joints and a lot of the stress off of your joints. And so that's a really great exercise to help with the pain. Weight management, if someone is overweight or obese, having a lot of knee pain, we'll talk about how to lose some weight to take some of that stress off the knee. Osteopathic manipulation. So I'll get into that a little bit later as I do osteopathic manipulation or OMT in my office. That helps a lot of people with knee pain and other types of pain. So some people might need an assistive walking device like a cane or a walker to help them with their pain, or a knee brace, or sometimes heat and ice can work. So if we're talking about pharmacology, typically I'll try something topical first, like a cream or an ointment before, taking a pill. So a topical NSAID like Voltaren gel is now over the counter. That's really great for pain. Also capsaicin. So this is actually derived from hot chilies and it's turned into a cream, and that's now over the counter as well. And you can put that on your joints and that helps relieve a lot of pain. If I have someone who has osteoarthritis in multiple different joints, then sometimes we'll talk about an oral NSAID like an Advil or Aleve or something like that. However, especially in older adults, I'm very cautious because NSAIDs can worsen your kidney function and affect your kidneys. It can also affect your GI system. So sometimes it can cause like a GI bleed. So that's just on rare, instances that I'll talk about oral NSAIDs because it does have a lot of side effects. And again, if the osteoarthritis is pretty severe, we can do steroid injections as well. That is just a short-term solution, but that is a possibility. So what is OMT? So it's a set of manual treatments intended to correct structural restrictions, which may be interfering with the body's healing capacity. And it's pretty gentle. I do, it's hands-on, and I describe it as sort of a mix between getting a massage or going to a chiropractor. So it's supposed to, as well as decrease pain in different areas of the body. So I use a lot of muscle energy, counter strain, myofascial release. These are all gentle techniques. And also, these are probably the three main ones that I would use for like knee pain, hip pain, back pain. I don't do a lot of cracking or thrusting, especially in older adults. It's not, not always necessary and can sometimes be harmful in certain situations. It just kind of depends on my patient's background and everything else they're going through. But these are pretty great techniques that I use in my office, all the time to help relieve people's pain. So, so why OMT? It's comprehensive. So again, I always do a thorough history and physical exam, and it's pretty safe. You can use it in addition to other treatments and other management of diseases and illnesses. And it's very gentle and calm. And I love this picture. So my parents were here visiting from Virginia not too long ago, and my dad is having some hip pain and knee pain because he has osteoarthritis in both his hips and his knees. And so, so that's a picture of me doing some osteopathic manipulation on my dad in my office. So it's pretty safe, gentle, and very effective to help ease people's pain and help people with their function and their day-to-day life. So that's my email address and my phone number. I'd love to answer any questions that people have. And I'm also going to try to send this back over to Phil.
Awesome. Well, thank you. And while you're doing that, Alex, I just wanted to throw in a couple other things here. First and foremost, when Dr. Barr was talking about the examination that she does, if you're seeing any healthcare provider, they should definitely be doing a very holistic examination, right? So whenever we see someone for the knee, we aren't only looking at the knee, we're looking at areas above and below that. So if you are seeing someone for a specific area of pain and they're just kind of looking at that one spot, that there could be something missing, right? Not that that's wrong, but we need to look at other areas too, just to make sure we look at the whole picture and make sure that we're treating everybody, not everybody, sorry, treating the whole situation, right? Making sure we get into the true root cause of the situation, treating everything that could be causing the pain. Another of those things that Dr. Barr brought up was some of the use of imaging and the use of steroid injections as needed. I know this is a conservative treatment seminar, but sometimes those things are necessary, right? To make sure that, again, we're looking at the whole picture. And in order to get to some of the most effective conservative treatment, sometimes we do need to take the edge off of things with an injection, or even the use of some oral medication like NSAIDs and some of those other things she talked about. So, and I've found that those have, for certain people, those things have worked very well when they get the injection and then within a few days after are starting some conservative treatment, such as physical therapy, exercise, movement, hands-on treatment, all of that. Those things can work well together. So we talked a lot at the beginning about avoiding those things. However, they have a time and a place, right? Whenever we're talking about the treatment of these types of conditions.
Yeah, exactly. If you're trying something conservative, over weeks or months, after a good period of time, like 3 months, if it's not getting better, then you will have to resort to other treatments. But
other treatments.
Good point.
Yeah, exactly.
Yeah.
So I just want, sorry, go ahead.
Like you're saying, if you're seeing someone about a certain pain or a certain issue and they're not doing something thorough, like a thorough history taking, and they're not actually touching you and putting their hands on you, then you want to find someone who is thorough. So
definitely. Yeah, those are just a few key things I wanted to key in on from what you said,
Thank
because
you.
I think those are an important message to get across. Does anyone have specific questions about what Dr. Barr just went over before we move on? If you'd like to just put them in the chat, we can answer them after, kind of answer them as we go. But if you have specific questions, please don't be afraid to type them in the chat or unmute yourself real quick and ask. If not, we'll kind of move on here a little bit. I kind of want to segue into talking a little bit about the arthritis end of things specifically, because that's what Dr. Barr focused on, and a few other things that I kind of wanted to touch on today. So I am going to share my screen real quick. Just want to show you an image of the knee, just so we can get a good idea of some of the structures that we're talking about here. So this is the knee joint. These are your quadricep muscles up here. Those are what straighten our knee out. That's our kneecap. If we take a closer look, we have our kneecap. The bottom of our femur, which is our thigh bone, and the top of our tibia, which is our shin bone, make up that knee joint. We have got the meniscus across here. I'm sure everybody has heard of the meniscus. That's what gives us our shock absorption in the knee. And then we have the LCL, or the lateral collateral ligament, the MCL, or medial collateral ligament. You have the ACL here. I'm sure everyone has probably heard of the ACL, and back there is the PCL. So those are all the major stability components of the knee. And when we're talking about arthritis, what we're talking about is inflammation in the joint, where some of this cartilage that's right on the bone here and here, and the meniscus are starting to wear down over time, and in some cases become inflamed. Okay, so this is a natural process that is going to happen over time, especially in some of our bigger weight-bearing joints, or joints in our body that take a lot of stress. So our knees, our hips, and our spine are the most common areas to see osteoarthritis. But as Dr. Barr said, you can see it in many other places as well. But those are the areas that tend to take most of the force that we put on our body during the day, whether we're walking, running, going up and down stairs, or for the sake of our spine, even sitting, right? Because the spine is holding us upright all day long, no matter what position that we're in. So it's going to happen to everybody. And to illustrate that point further, I'm going to show you another quick study here. This is my favorite study. This is called the VOMIT study. So the Victims of Medical Imaging Technology study. So that was one of the reasons I brought up the caveat of sometimes imaging is just necessary for us to get all of the information. But if we look here at the knee section of this study, 85% of adults with no actual knee pain have x-rays that show arthritis. Okay, so it's arthritis is inevitable for all of us, which also means it doesn't have to be painful, right? So just because we have arthritis in a knee, in a hip, in our spine, does not automatically mean we're going to have pain. And this one I love. Healthy professional basketball players, 48% of them had meniscus or cartilage damage on their knee MRIs. So often I hear people say that, oh, my doctor took an x-ray and I have bone on bone arthritis, or I had an x-ray or an MRI and I have a meniscus tear. If you had an x-ray and they told you had a meniscus tear, I'd question that a little bit, because you're not going to see that on an x-ray, but that's a different discussion to have. But the point, especially with the pro basketball players, I don't think we have any pro basketball players on the call. If we do, please let me know. But the point that really drives home is that if we really take care of areas in and around our knee, we can perform at a pretty high level without pain, even when tearing might be present, and or when arthritis might be present in our knee. Because pro basketball players have tons of people on staff that are just keeping them at their peak physical performance all the time, and they're able to run miles and miles and miles in a game, up and down the court, jump, all that stuff, and land and not have pain, right? And almost half of them have physical damage to that shock absorption material in their knee. Okay, so I say that just to illustrate the point that just because we have a finding on an image that maybe was ordered for us for whatever reason, does not mean that our options are limited, or that it's just something we have to live with, or it's not going to get better because arthritis and tearing doesn't get better unless we surgically take care of it. those things can be present without pain. And if we can treat them conservatively quite effectively and restore normal amounts of function, even with those things being present. Sometimes, especially with meniscus tears, if some of that meniscus is kind of, we call it a bucket handle tear, it actually kind of flaps into the joint a little bit, and your knee's getting like stuck or not moving. Sometimes it's warranted to go in there and get that taken care of for sure. But trying a conservative approach before we go down that road is often warranted. Okay. One great thing, and Dr. Barr, I'm really curious if you've ever seen this study in particular. Let me make sure that it's queued up on my computer here real quick. But this is a study that actually looked at arthroscopic surgery. So arthroscopic partial meniscectomy, which means they went in and actually took out a little bit of meniscus, versus a sham surgery. So they basically just pretended to give these people surgery. Okay. Both groups got exercise prescription and basically physical therapy afterwards. Okay. It wasn't as structured and regimented as a physical therapist as I would have liked to seen, but it was an exercise program where they were given some guidance and support along the way to work on. And in the end, there was no, and you can see through here, there were really no differences between the groups, nothing statistically significant. There were no significant differences between the groups in the number of patients who required subsequent knee surgery or had serious adverse events. So throughout this trial, all of these people had tearing in their meniscus. Some got surgery, some did not, and they both got exercise after their procedures, whether they got a procedure or not, and the outcomes were the same, right? Long-term outcomes were the same for those people. So that just goes to show you that that surgery, especially when we're talking about an issue with the joint itself, is not always absolutely necessary, and conservative treatment is a good thing to try first. So let's see here. We had a quick question pop up that I'll address real quick. Even with ACL tear, you believe you develop the knee muscles strong enough to perform without pain? That depends. ACL is a little different because the ACL has to do with a lot of structural stability within the knee. So it really depends on what you're talking about as far as performing. Okay. If the person is an athlete, a very small percentage of athletes can still perform at that level with a torn ACL, but it's a very small percentage. It's like somewhere between 1% and 3%. An average person, if they aren't like a hiker or skier or someone like that, and they just want to be able to do a little bit of exercise, maybe some strength training, a little bit of light cardio, and be able to get around day to day, it's certainly possible. But in a lot of cases, especially if you have someone who's, let's say, middle-aged or younger, it's still going to be worthwhile them getting that ACL repaired so that they don't have to worry about more future complications, because having that lack of stability could put a little more stress through certain areas of the knee if they don't have the right amount of stability there. So ACLs are different. ACLs are different. Usually when there's a tear in a ligament, that's worth repairing, especially when we're talking about middle-aged folks.
Yeah, especially, it's going to depend on the size or degree of the tear, and certainly the age. So, right, just like what Phil is saying, if you have a younger adult with a pretty significant tear, you're going to want to get that repaired just because, help for the rest of their life versus, a small tear in an older adult. You can, I love that study, because even there are studies out there that show even like one or two exercises that strengthen the muscles around the knee significantly, increase your quality of life and decrease pain. So we're not talking about like a long list of like 10 exercises. Even if you just focus on one or two, strengthening those muscles around the joints, huge difference. So
definitely.
yeah, absolutely.
And to drive that home even further, I'm gonna show you another quick study. This was a study about prehabilitation. So people that were going to be having total knee replacements and getting rehab beforehand. And they looked at people who did, and they looked at people who didn't. And what they found here, as you can see here, is that the knee and function scores increased in the group that got prehabilitation leading up to surgery. So that means they felt their knee was better, they felt their function was better, even though they continued to have surgery. When we looked at after surgery, how they felt about their knee was significantly different at 3 months out and 6 months out. And you can see here the program provided better post-operative knee score and function score at 3 months, and the knee score up to 6 months. When you get out to about a year, there wasn't a whole lot of difference. The importance there is, and Dr. Barr, I know that you'll appreciate this, and you've seen this as well. The first 3 months after a knee replacement is the hardest to begin with. So if you are getting a knee replacement, working on it conservatively beforehand can do a couple things. One, it's going to make that knee just move better, and your function, your ability to move and do things during your day is going to be better. Anecdotally, I've had many people wind up saying, hey, I don't need that knee replacement anymore. I'm going to keep trying to work on this conservatively. It takes maybe a little bit more time. I believe that study was about 6 to 8 weeks of treatment. Some of those people take a little bit longer than that, but usually they get around that 6 to 8 weeks and they see enough of an improvement and some light at the end of the tunnel that they say, hey, I want to at least push this off a little bit more. I'm not going to go back to that 8-week follow-up with the surgeon, because I think we can work on this a little bit more and fend it off. And we can. But even those people that still have surgery, the first 3 to 6 months after surgery, which is the hardest part of recovery from a knee replacement, they feel better, and they do better. Another quick little story, anecdotally, I had someone who was getting knee replacements on each leg 6 weeks apart. Okay, so saw this person within a week or two after their first knee replacement. We worked on things for 6 weeks. We worked on both of her knees. Okay, we didn't just work on the knee that was replaced. I gave her a lot to work on, and her and I together worked on things on the left side as well as the right side. After she had her second surgery, I saw her a couple weeks after that. So at this point, we had been working on things on both sides for about 6 to 8 weeks. The left knee, which was the second knee done, moved better and got more motion faster, both in bending and straightening, than the first one did, because before the first one, she hadn't worked on anything. Okay, so that's comparing within the same person. So,
yeah, that's amazing.
Similar process, right? The process to get her to a point where things were painful enough to need a knee replacement was happening on both sides. I mean, even imaging, I know we just talked about how that's not super important, but in this case, it didn't really matter which one she got done first. They both looked the same on imaging. They were both in need of replacement, and the left knee progressed a lot faster than the right one because things were working better. And it was much less of a problem for her in the full bout of her recovery. So the point there is, again, conservative treatment, even giving it a try and really committing to it, can yield you good results. And worst case scenario, your recovery after a surgery as significant as a knee replacement is going to be easier, especially within that first 3 to 6 months, because you're just moving and feeling better. Okay.
Yeah, total knee replacements, that's a hard surgery and that's a hard recovery. There's a lot of pain involved. So whatever you can do pre-op to make it better, post-op to make it better, and that's mostly, exercise and physical therapy, then it's a lot smoother, because it's a pretty hard surgery for people to go through.
Yes, it is. It's very involved, and it's basically like carpentry for your knee. It's a rough surgery.
Yeah.
The process of the surgery is hard. So anything you can do to make that better on yourself is important. And before we jump into a few exercises here to show you that can help with some knee pain, Dr. Barr was just talking about a couple exercises you can do. I just want to share one more thing with you that just further drives home the point that movement, exercise, and even something like running, if any of you are runners and have knee pain, or know someone that's a runner and has some knee pain, it's not something they should stop completely. They might just need some help with it. So I want to share something with you here. This was a great study published back in 2017. And what this study looked at was arthritis in 3 different groups of people: people that ran just recreationally, like running for exercise; people who are very sedentary, right? Your average couch potato, I guess is a good term for it; and people who ran competitively. So these are, high level marathon runners, the type of people that run and win the Beach to Beacon here in Falmouth, Maine every year, those types of folks. So recreational runners only had about a 3.5% prevalence rate, or incidence rate, excuse me, of osteoarthritis, where people who didn't run, have never ran for exercise, had 10.2% arthritis in that group. Competitive runners, again, that's at a really high level. That's a lot of force put through the knees, a little bit more. But what this really drives home again is that certain types of activities we might do on a day-to-day basis, going up and down stairs, heck, even running, are not going to make us more likely to have arthritis or have that area become painful from arthritis. Okay. Now, if you are not a runner, I don't suggest you go start running 5Ks today because it's going to like help your arthritis. Again, the point is that our knees and our bodies in general are built and designed to take the stresses we put on them. Like Dr. Barr said, 2 to 5% of our body weight they can handle very regularly. Running puts it at the high end of that. I think it's somewhere between 5 to 7% of our body weight. But even if you are a runner and maybe you've stopped recently because you have some knee pain going on or something like that, that knee pain can be treated conservatively. And then a progression back to running is 100% possible. Running is not something that I think anyone, unless they have a lot of different problems going on and they haven't taken care of those problems well, running's not something I would tell anyone you absolutely have to stop. I've worked with many runners and very, very physically fit people into their 60s and 70s. And yes, they have some things crop up, but if they work on things conservatively and they're consistent with those things, they can still run at a certain level, even well into their 60s and 70s, if that's something that they want to do. So physical activity is not a bad thing. It's not going to damage things more. We just have to make sure we have the right amounts of mobility, stability, and strength and endurance around those joints to make sure we're not putting too much stress on them. Okay. Any quick questions before we jump into a few exercises here? I know we've kind of thrown a lot at you here, but if you have questions, please throw them in the chat. What we're going to talk about next, these exercises are really designed to address those imbalances I just talked about, because these imbalances where the knee's not moving as well as it should be, areas around the knees and the hips and even down at the foot and ankle mechanically aren't doing what we need them to do as well as they could be. Those things put more stress on a knee. And if we put more stress on a knee when we're moving, that doesn't have the cushion that it needs to handle that stress, because we have some arthritis, maybe we have some tearing in the meniscus, whatever the case might be, that's what causes that area to become more painful. Okay. So again, I stated earlier, the presence of arthritis or a tear alone doesn't cause pain. It's if that area has more stress placed on it because of some imbalance in and around that joint above and below it, that puts more stress. When we're putting 2 to 5% of our body weight worth of force through that knee, it's not going to like it if it doesn't have the support that it needs to do it. Okay. So the exercise program I'm going to go through with you today, and I will send this to all of you as well. The exercise program is designed to address those imbalances in a way that will kind of reset a few things, get some things moving, get some muscles activated, and then secure that a little bit. Okay. So we're going to go through a few of these right now. You can certainly try some of these as we go. This first one is just going to look at some flexibility of the knee. Okay. So this is called a heel slide. So if you're lying on your back, you're going to take the knee that you're working on, and you can do this on both sides. It's not going to hurt to do, even on the side that isn't stiff or uncomfortable. And all you're going to do is slide your heel up as far as you can, just until you get a good stretch here through the knee. Hold that for about 3 to 5 seconds and slowly come back down all the way straight to the starting position again. I have people do 30 of those at a time, 3 times a day. Okay. So if we're trying to improve flexibility around that knee joint, we have to do enough at one time to actually get improvement in the tissues around the joint and in the musculature to lengthen them. And we have to do it frequently enough during our day to make sure that we're actually getting true changes in those tissues. This should not be painful. If you're cranking into pain, you're going too far. You will feel you will feel the stretch before you get to pain, or you should, and don't crank into that. Okay, that's the real important part there. Okay, the next one, and again, please ask questions as we go if you need to, or if I'm going too fast, whatever the case might be. The next one is going to be quad sets. So this is incredibly important because when we have pain and swelling in the knee, and it doesn't take much swelling, it only takes 1.5 ounces of fluid in and around the knee joint, and the knee joint's a very big joint, to cause your thigh muscles, your quads, to shut down. Okay, so 1.5 ounces of fluid. A good picture for that is a shot glass, right? Just that amount of fluid is enough to cause the quad muscles here to shut down. So to get those activated and working the way we want them to again, put a towel under the knee. You're going to squeeze the thigh muscle and push the back of your knee down into that towel. Okay, holding for about 5 seconds. You can do 10 of those, 3 sets of 10. And again, you can do this on both sides. You don't just have to do it on the one side. That is another one we want to be doing a little more frequently, because if we have active pain or swelling going on, that quad's not working the way we want it to. In order for the rest of these exercises to work, the quad has to be working well for us. Okay, so doing that 2 to 3 times a day is great. This is the best, clearest picture I could come up with. I always have the person's other knee bent when they're doing this, to take stress off your back, actually, when you're lying flat on your back. So that's just a little caveat I'll throw in there. A progression from that is to then lift the leg up straight. One thing I'll say is, if when you go to lift this leg up straight, you can't keep your leg fully straight like it is here in the picture, we need to do more of the quad sets before we move to the straight leg race. Okay, so before you lift that leg up straight, you need to do a quad set, hold that quad set, that tight thigh muscle, the whole time that leg is coming up and back down, then relax and then tighten again and lift again. Okay, that repetition of doing that tells our body, hey, when I do this type of activity, when I want this muscle to work the way it's meant to work, this is how I have to do it. Okay, so that repetition of contracting, lifting, coming back down, relaxing through your 3 sets of 10 once or twice a day is incredibly important. Okay. So once we have some muscles activated in around that knee area, we also have to address some muscles up through the hips to get more of the stability of the knee, because our hip strength and stability is super important in the amount of stress that's placed on the knee. So if we're only working on stuff around the knee, we're going to miss the boat a little bit. Okay. So this is side lying hip abduction, lifting the leg up straight to the side. Again, this can be done on your bed. Some people have to start with a pillow between their legs so that their leg starts a little bit higher. So if you feel like it's too hard for you without the pillows, put a pillow between your legs, so you're not starting basically from with your leg on the bed. The real important thing here is that your upper body, your hip, and your leg are all in a straight line when you're doing this. Okay, a lot of people like to have their leg cheat forward a little bit. It starts coming directly forward. And that means we're compensating with the front of the hip, and we don't want to do that. You should feel this right on the side of your hip. Okay, that's the only muscle that should be doing this. I have people do 3 sets of 12, and once a day is fine with this one as well. You can switch legs each 12 so you don't get too tired and fatigued and start to compensate on one side. That's a great way to isolate a muscle for a lot of people that's very weak, because we don't work it and stress it much in our day to day. The last one I'll share with you is a sit to stand, which is basically a squat, right? We're getting up out of a chair. Couple things to remember here. One, making sure that our feet aren't too far in or too far out away from the chair. You can see that his knees are pretty much just over his ankles here. Maybe knees are forward a little bit. As he leans forward, his chest stays up nice and tall. And what I tell everybody to do is when their hips and their buttocks start to leave that chair, we squeeze those buttock muscles as you get up out of the chair. Okay. That's real important to get your glutes, your buttock muscles, and your quads, your thigh muscles should be the muscles doing this activity for us. I showed a picture here with the hands on the chair, because if you need to use your hands to steady yourself, that's kind of level one. You can progress this by not using the chair, and you can progress this even further by, instead of sitting down when you come back down, just tapping your hips on the chair and coming back up, and that's a full squat. Okay. But really making sure we're getting your glutes working while you do this is real important to take stress off of the knee. And this can be done once or twice a day as well. I usually have people do 3 sets of 10 of that. And you can split those up if you need to. If you need to do 10 at a time, 3 times a day, that's perfectly fine. Wherever's a good starting place for you, and wherever, whatever starting place is needed to not have pain with this activity is real important as well. Questions on those things. Again, I know I threw a lot at you there, but want to give you all a little bit of time here, just for a general question and answer session before we wrap anything up. So if you have questions, you can either type them in the chat or unmute yourself and ask the question. So I have one more quick little thing I want to share with you and let you all get to your beautiful Saturday. Okay, no questions. Great. That must mean Dr. Barr and I did a real good job getting all the information across.
Everyone's really quiet,
right? which is fine. So the last thing I just want to put up a little bit of contact information for you all. Oh geez, it's gonna be slow on me here. We do have. Oh, you're very welcome, Joanne. Thank you for joining us. Just got one more quick thing I want to share with you real quick, just so if you all do have questions that pop up after the fact, you can get a hold of me for those questions. Let me just share my screen here. Oh, we did have one quick question here. Is it best to get a knee replacement at an early age or postpone it while doing PT? Good question, Nancy.
So do you want me to answer that, or
go ahead, give your answer, and then if I have anything to add, I will.
Sure.
I will jump in.
So, I mean, it's just going to depend on your function and your ability. There's not necessarily like a best age. It's going to be, if you can hold off on surgery by doing exercises and PT and just managing the pain, that's better than having a pretty big invasive surgery. But, if someone gets to the point where we do 3 to 6 months of conservative treatment and the pain is getting worse and it's pretty severe, then you want to go ahead and have a surgery. So it's not really about, an early age versus a later age. It's more about like function, mobility. And if all of these conservative treatments aren't working, then, a referral to an orthopedic surgeon is certainly, appropriate.
Yeah, I agree 100% with all of that. The only other thing I'll add in is, if you are starting to have some knee pain, even if it's off and on, right? You only feel it with certain activities you do. And if you don't do that activity, it goes away within a couple of days. That's still a fantastic time to get it looked at by a physical therapist, or you can talk to your doctor certainly, but you can also reach out directly to myself, physical therapist that you've worked with before, whatever the case might be. Because the sooner we treat some of these imbalances, Jennifer, thanks for saying that. Yeah, get going on those as soon as you can. The sooner we treat these imbalances and pick up on them, we can fend off the decline in function, right? I think a lot of people,
I would rather have my patient come to me and say, oh, I'm having, a little bit of pain. I don't really want to bother you, but I just want to throw it out there. Like, I'd rather have someone tell me I'm having pain or this is what's going on early, versus wait until it's really severe and it's really impacting your life. Because the earlier you intervene and do all these exercises, the better you're going to age and the better you're going to do.
Yes, agreed. Yep, 100%. And then another question that leads into this really well. I had knee pain in one knee and now it has spread to the other knee. Will the pain possibly disappear in the other knee once the main knee is taken care of? yes, that can happen. If you're compensating for the knee pain on the right side, let's say, and your left knee starts to bother you, or vice versa. But these exercises we just went over, like I said, you want to do these on both sides, even if one knee's not that bad, or even if one knee isn't painful, it's still good to work on these things. So we have a really good foundation there. And again, these are very foundational exercises. There's a lot of progression that needs to be done to get you to a point where conservative treatment's going to take care of it for you. But this is these exercises we went over are a great place to start. But yes, if one knee gets better, or you're just at a point where that one knee needs surgery, by doing the exercises and the PT following up after surgery on both knees, you can take care of that other knee conservatively. It's happened many times. So that's a definite possibility. Another question here, about an ACL tear, recommend surgery. Said I can gain strength by working on the knee and still play. What do you recommend? Without examining you, hard to fully answer that question. But at 27, you want to be active.
Right. You're pretty young.
You're young, you want to be active and continue to play soccer. It might not be at a huge competitive level, but heck, even some of those rec leagues can get competitive, especially depending on where you're playing and who you're playing with. I think if you want to be active in the future and prevent, because another thing that can happen with a torn ACL is if you have a lot of extra movement in that knee, even though your PCL can cover some of that, which is what you mentioned there, and the muscles around it can cover some of that. If you land wrong, you could possibly tear an MCL. You could do a lot of damage to the meniscus, have a lot of tearing in the meniscus. A lot of people, when they tear an ACL, tear their MCL and their medial meniscus along with that ACL injury. So even if that wasn't the case for you, even if you just have the ACL tear, one, good for you, you didn't damage anything else. But by not getting it fixed at such a young age and wanting to be as active as you want to be, it might not be a bad idea to get it taken care of. Again, the whole point of this workshop is to try conservative treatment, but with an ACL tear, it's a bit of a different story. You know, if you were 47, 57 and you didn't want to keep playing soccer, I would say, hey, maybe we can, handle this conservatively and get it stronger and not go the surgery route. But at 27, you're still active. You still want to be active. It might be for you that's better, that the surgery is a better option.
That would be my biggest fear would be, if you want to keep playing soccer, you want to keep being, active, that you could potentially, hurt and tear other things.
Right. You might wind up needing a surgery anyways, right? If something freak accident happens. So,
and it's always good, to get a second opinion. If you have one orthopedic surgeon telling you something, sometimes it's good to just get a second opinion. So I would also throw that in there.
Yeah. I love erring on the side of conservative approach. That's kind of the bread and butter of physical therapy and what we do, which is maybe why the PT is urging you to do that, because maybe they're seeing something that would indicate that it will work for you. There are people that we call copers who can cope with that and not need surgery, but it's a very, very small percentage of people. Very small. It's like, again, 1 to 3% of people with ACL tears can cope and not have any instability and not have problems. So second opinion might not be a bad thing in your case. So real quick before we wrap up, I just wanted to share my contact information with you all. This is how you can best get a hold of me. Phone calls or texts at that number are perfectly fine. And you can email me as well. More information about my practice is on my website as well. I will make sure that we have all of this contact information in the follow-up email that I send you all today after the workshop. And I will make sure that you have a link to be able to download that exercise program as well. Definitely want to thank you all for hopping on and joining us today. It was a lot of fun. Dr. Barr, thank you very much for your time as well.
Absolutely.
Really appreciate it. Can't thank you all enough for that. And what I always like to do as a thank you to the people that join my workshops is I really am passionate about doing conservative treatment, preventative care for people. So I was able to open up 3 spots on my schedule next week for some screenings. These kind of holistic knee pain prevention screenings I would normally value at $150, and I am doing them for $75. So I'm taking half off of that just for 3 people that were on the workshop today that would like to just have someone take a look and see what a treatment plan could look like for them. If you would like to take advantage of that, you can certainly put your name in the chat and I will get your information. You could also reach out later and take advantage as well. But I just wanted to offer that all to you as a thank you for joining us on this beautiful Saturday morning. Really, really appreciate y'all taking the time.
Yeah, enjoy the beautiful day out there, everyone.
Yes, enjoy. That is all we had. So if you want any more information, have any more questions, please feel free to stay on. Be glad to answer them for you. But if not, have a great day. Thank you, everybody.